for standing by. At this time, all participants are in a listen-only mode until the question-and-answer session of today's conference. At that point, if you would like to ask a question, please press star 1. The call is being recorded. If you have any objections, you may disconnect at this point. I will turn the meeting over to your host, Ms. Pedzark. You now begin.
Thank you, everybody. I welcome you to our first of hopefully many North Dakota Mission Lifeline stroke webinars. Our goal is to have these quarter topics, of course, will change every quarter depending upon what we have requests for education on. Hope to engage individuals from the pre-hospital as well as the hospital settings and even into cardiac rehab also. Begin today. My name is, well, first of all, myself. I am Jana Petchak. I am the North Dakota Mission Lifeline Stroke Director, and I have with me Mindy Cook, who is our AHA Senior Director of Quality and System Improvement here in North Dakota, as well as Minnesota and Wisconsin. We will, at the end of the call, there'll be a time for questions if you happen to have any questions for us or any of our speaking in our panel. We will get started today with our actual WebEx here. We have, to begin with, we have Dr. Shiraz Hyder, Neurologist and Medical Director of the Stroke Program at CHI St. Alexis Health in Bismarck. He received his medical degree from the Dal Medical College in Pakistan and completed his neurology residency at Medical College of Georgia. Dr. is board certified by the American Board of Psychiatry and Neurology and is a fellow of the American Academy of Neurology, American Heart Association, and Stroke Association, and American College of Physician Executives. Dr. Hyder also currently serves as the chair of the State Task Stroke Force in Dakota and is co-chair of the North Dakota Mission Lifeline Stroke Project. So with this, I'll turn things over to Dr. Hyder to give an overview of the Mission Lifeline project here in North Dakota.
Thank you, Anna. Hello and welcome to all our friends and colleagues across North Dakota. As Jana mentioned, this is the first webinar in a series of webinars to come. This webinar is really to introduce an exciting new project that is known as the North Dakota Mission Lifeline Stroke. The project is actually a statewide endeavor to expand and enhance stroke care in North Dakota. And many of you online today have been working with us on the state task force to develop the stroke system of care. This project really helps take our work done already through the stroke system of care force to a higher level, to the next level, is to be more comprehensive, and we'll talk about the detail in a minute. Can I have the next slide? Okay, thank you, Jana. The slide prior, previous slide, Jana. Yes, thank you. So the exciting part is that American Heart Association and American Stroke Association has announced a statewide commitment of $5.6 million for the Mission Lifeline Stroke project that I just mentioned. And the initiative is to expand and enhance stroke care in North Dakota. The funder for this initiative is the Leona and Harry Hemsley Charitable Trust. North was chosen amongst many other states because what I believe is the good work that has already been done by the state task force, and also because of the rural nature of our state. We're truly blessed in our state to have such wonderful healthcare teams across the state, whether we are talking about from Grand Forks to Bowman, North Dakota, or from Williston to Wahpeton, North Dakota. Whether we are talking about the volunteer EMS to a critical access hospital nurse or to a stroke specialist in a tertiary care hospital, everyone has been working towards a common goal of providing the best care in a timely manner to a stroke patient. So it's wonderful to have everybody together join us today and go over a little bit about the stroke statistics. I think most of you know that there are about 100,000 people in U.S. that have stroke every year, so we're not talking about a small number. And stroke is the number 5 cause of death in USA. It used to be number 3, then number 4, but with all the good work that has gone on for prevention and appropriate intervention, it has now become number 5, which is excellent. We hope to see it become 6 and 7 and keep on becoming less and less. A little about stroke statistics. More women than men have stroke each year. That's partly because women live longer. Even children are not immune to stroke. The annual incidence of stroke in U.S. children is about 6.4 per 100,000 children. And you all know about the classification of stroke between ischemic and hemorrhagic. 80% of strokes are classified as ischemic. Although the numbers may be a little different in the southern part of country in U.S., especially in the stroke belt, where there may be a little bit higher incidence of hemorrhage, or in South or Far East Asia, where there seems to be almost 30% incidence of hemorrhagic strokes. So it's the leading cause of serious long-term disability. It's actually one of the top diagnoses for admissions to nursing homes. It reduces mobility in more than half of stroke survivors age 65 and over. And approximately 1/3 of stroke survivors who return home experience a loss of their ability to function. There's poor quality of life, isolation, depression, and greater risk of death. So is the Stroke Project, what is the framework? We have a good opportunity for stakeholder coordination. This includes as I mentioned previously, the North Dakota State Stroke Task Force. We also have created a subgroup of participating hospital advisory group. Then we have the Physician Champion Advisory Group. We have the hospital group that includes our wonderful EMS people. Then also have another group that consists of telemedicine and rehab. Within the framework is going to be a public education campaign. This is going to be focused on recognition of stroke signs and symptoms and the need to activate 911 system. As you all know, that we have a lot of people that still don't show up in time to seek medical attention, and we have to really reach out to those, especially in the rural areas, to understand the importance of timely intervention. We also have a system-wide data tool to assess protocols, in which we're sharing the following slides. We'll be developing guidelines for the EMS and hospital personnel. There's going to be a regional plan for rapid transport and interfacility transfer of patients. This is particularly, you all know about the drip and ship, but we also are developing centers where intra-arterial intervention can take place. We have to have a system of care where a patient is transferred to the appropriate facility where they will get the most optimum care. Next, to address the barriers that exist for access and quality of telemedicine, which is becoming a pretty important tool across the nation for timely intervention. And then, of course, we'll have to come up with a program to provide rehab care even to those who live in rural areas. Next is the peer-to-peer stroke survivor support network, which we have not developed in the past, but it will be an important task to take. We mentioned a little bit about the public awareness. And NABU agency is a marketing agency that will be conducting research to identify and discover the barriers to calling 911. There the president of MAB has already come and talked to me, and we are discussing ways of how we can improve the communication and education of the public as far as the warning signs of stroke are concerned, and so they can seek immediate attention. There'll be an effective communication campaign that is rural-oriented and will target one or more of the barriers that will be identified through the research, and we'll monitor the impact of metrics and provide analysis. Please. So the system-wide data tool, I think many of you are already familiar with it, especially the stroke coordinators across the state who do a wonderful job. They have been reviewing this data and sharing with their stroke teams. And of course, get with the guidelines is a very important tool to use. Next slide, please. Something I'm sure that you all may have seen before is it's showing the GPA arrived by 2 hours, treat by 3 hour data. As you can see, compared to all hospitals across the country and North Dakota hospitals, we have some work to do. But the good thing is you can see improvement. I think the rest of the country seems to be staying static, and we are gradually improving. It's all because of the wonderful work that all of you are doing, and not only the primary stroke centers and tertiary care areas, but also the EMS and critical access hospitals. Everybody coming together, and I think we'll keep on improving this care, and hopefully next year we'll par with the data that represents the entire country. Here's an example of what the pre-hospital care data collection will look like. I think it is being shared with the EAPS already, and we'll also be having a post-discharge data collected. The follow-up and the outcomes are very important to see if we are, what kind of impact are we having. Many of us have not been really collecting that, but it'll be good to know how we are impacting the stroke outcomes. Then is the education that we're talking about. This is the first step. We'll be doing quarterly noon-hour webinars. There'll be regional workshops starting in spring, focusing both on stroke and cardiac. And of course, we have our annual conference for cardiac and stroke care. The coming year, the 2018, is on October 24th and 25th in Fargo. So your calendars for that. We also plan to do on-site and remote education for EMS as well as critical access hospitals, and go over the eligibility for use of TPA, destination decision-making in terms of is intra-arterial intervention available or not, and is intravenous intervention available or not, and so forth. And of course, the stroke severity screening we are working on through the Stroke Task Force. There's more to come on as far as the FAST ED score is concerned. That's something that incorporates the ideation and neglect and denial. So it's not just the FAST, but adding the ideation as well as the neglect and denial concept. And so that's a lot of good work has been started, but we need your support. We'll come to you. We'll discuss in detail how we can work together. I think we have a very exciting opportunity to further improve the care that we provide to our stroke patients. I look forward to working with all of you. And I will let the next speaker take over at this point.
I have just a couple more slides of yours prior to.
Yeah. So the North Dakota Stroke Survivor Network is another important that we'll be working upon. This is again more based on the survivors, their families coming together in more like a support group, which is statewide and helping each other. So, the goals are to increase adherence to follow-up appointments, provide encouragement, support, and guidance, educate stroke survivors on need for treatment compliance to reduce risk of stroke recurrence. This is the secondary prevention we have talked about. We'll seek referral guidance from the hospital staff when survivor needs are identified, provide stroke volunteers the opportunity to give back. Have had a similar journey, a stroke. And facility care coordination. So, you know, is giving us the resources, and this grant is going to be distributed amongst the participating hospitals. And for that, we require that each organization identifies a physician champion. There needs to be a subcommittee that will participate in our project. They have to participate in the Get Fit the Guidelines. There'll be an EMS follow-up as well. We'll have to adopt the North Dakota Survivor Network. They'll have to participate in education, both for public as well as the staff, and they also have to adopt the North Dakota Survivor Network program that I just mentioned. So I'm ready to hand over to the next speaker. Thank you.
Yes, thank you very much, Dr. Hyder. And I'm going to turn things over actually to Geraldine Alexander, stroke coordinator at Trinity Health in Minot, and she's going to introduce a stroke survivor that she had with her.
I'm very pleased to have one of our stroke survivors that's very active in our stroke survivor group here at Trinity. His name is Jerry Sennett, and he had a stroke just a little bit over a year ago. And so Jerry was nice enough to come back from vacation and participate with us today. So he's going to sharing his story. And so you might hear me in the background kind of prompting him with some idea of things to talk about, but he's just going to kind of share his story, and he'll be willing to take any kind of questions after the webinar is nearing the end. So go ahead, Jerry.
Or good afternoon, I should say. The vacation that I just came back from was supposed to happen about the 15th of November of this year, 2016. We didn't go to do that, so we did it this year. On November 9th of 2016, I was in Matt at a home we had just moved out of, and at the home we moved into, I built a shed, and I had back ordered a piece of metal for the metal. And out to the lumber yard at like 4:30 afternoon, took that up, and my wife, I'd be right back. She was at the home we'd moved out of. And I went to the yard, picked up my piece of metal that I come out and loaded it. 10 foot long, so I went through. I have a SUV and a smaller one, a crossover, and we had to run it through from the tail through the side window to make it fit. I opened the side door, the passenger's door, front seat, and pulled and passed it on up, and he put it through the car, and it wouldn't go past the headrest. So I told him, pull it back out, it won't fit. So then I opened the car door, and again, and leaned the seat back all the way. Step back to close the car door. My arm wouldn't work. My right arm wouldn't work. That's what that same arm that I just closed the door with. So I leaned in the window. I closed the door with my left hand and leaned in there and told him okay, and he brought it up there, and I hung it out the door. And around behind the vehicle, told him I got it, and he thanked him, and he walked away. I closed the tailgate and got in the car and back to where my wife was, and got out of the car. And when I couldn't get my hand in my right hand in my pocket to get my keys out, car operates off to the outside door and went the interior and knocked on the door, and my wife was on the phone. She come to the door and looked at me, why are you knocking, kind of look on her face. And I out that I think I'm having a stroke. And it went uphill from there. She sat on the couch, he called 911 and talked to the operator and asked them what to do, and they had the ambulance on the way within seconds. This took place within, that was approximately at the half-hour point from the time I'd left her. The ambulance was there within 2 or 3 minutes. Then I remember they came in, they had me sit on a gurney, and they wheeled me out the gurney and put me in the ambulance. My wife, in the meantime, is asking them how long. There's a timeline to get a shot, but she don't know what it is, and she was asking them what that line was, and I think they told her 4 or 4.5 hours from onset. So as we do the onset, they were in pretty good shape for that part. Anyway, we went on to the hospital, and I don't really remember a whole lot there, except after I got in there, I remember them pulling off me and talking to me and to different things, and then go get some tests, and put me back on the table in the ER, and me trying to touch my, and I looked like the guy that chicken slapping the heck out of, that barbecue sauce on his face. I couldn't touch my nose for nothing. But I did get the shot, and within just minutes, I don't know if it's minutes or how long it was, but I gradually got to where I could touch my nose before I went to a room. It put me in ICU. And, I don't remember a lot about ICU. I went in on a Tuesday, I believe it was, Tuesday afternoon, I believe it was, and course of my stay, I surprised them because I did get the shot in such a timely fashion. And the following day, the stroke team came around and told me, and everybody comes around and tells you what it's going to be like and all that. And after the first day, the speech therapist said, "I don't think you need speech therapy," and my wife said, "Imagine that." So I didn't have to do speech therapy. They did schedule me for occupational therapy, and to go to that, the first I got out of the hospital, I got out the following Friday. I got out, went in Tuesday, I was out on Friday, Tuesday afternoon till Friday. And they discovered the culprit was carotid artery was clogged up. After I got out, up with the
surgeon,
Dr. John, and what the problem was with the carotid artery, and what should be done, and what he would do it, how he would do it, and blah blah. And they got through telling me all about this. He said, "So what do you think?" And I'm thinking, well, surgery's going to be another week or two. And I said, "Well, I better get it fixed." And he said, "Well, that's good, because I got scheduled for surgery noon tomorrow." So the following Tuesday, I was in the hospital again. Yeah, got it following Friday after carotid artery surgery. Then the Monday, I went in for my first occupational therapy session. And after that session, the occupational therapist told me I didn't have to come back, but I informed him that he needed to have at least one more appointment, because my wife wasn't going to believe that either. So I'd go to occupational therapy twice. I'm one of the fortunate ones in that the fact that I recovered quite well. I got the shot early, very early, in comparison to how it happens sometimes. But I was off doing not anything for the first month, and then after that they let me do things, and I got back to driving the car, and I'm a gopher for the rest of the family, so I'm back to doing that. Errands. And then this year we did our vacation, which happened to be in San Diego.
You feel changed in any way since your stroke?
That initial time of recovery was pretty evident that things weren't the same. Sometimes I would be buttering the bread and the knife would just slide out of my hand, and I wasn't even aware that it was gone until I heard it hit the floor. I do things differently. I'm more careful. Probably isn't as good. My band was best beforehand, so that's probably not as bad as it could be. But other than that, do things anything I want to, but slower. I just have to pay more attention to where I'm at and what I'm doing.
Do you want to share a little bit about our support group?
Yes, we go in the support groups once a month, and I think that people talk, and I realize how fortunate I am, and then they hear me. A couple of people seem to be encouraged, but to hear that it's possible. You got to keep plugging away. And I advocate take them and keep on trucking.
I think back over to you, Anna, so you can have Dr. Sather do his talk.
Yeah, thanks, and thanks, Jerry. That is very helpful to hear from a patient's perspective. And Lord, Jerry, if you were up for it, if you could stay on until the end of the call, if anybody on the call has some questions for you also. So.
Sure, I will.
Perfect. But next, we are going to move on here. Dr. Jeffrey Sather began his career as a paramedic with the community ambulance of Minot and later as chief paramedic with Trinity North Star Criticare. David graduated from the UND School of Medicine. He completed residency in emergency medicine at St. Vincent Mercy Medical Center in Toledo, Ohio. He is board certified in emergency medicine and a fellow of the American College of Emergency Physicians. Sather is currently the chief of medicine at Trinity Health in Minot. He serves as co-chair of the North Dakota Mission Lifeline STEMI project and is also co-chair of the current North Dakota Mission Lifeline Stroke Initiative. He is a member of the State Trauma Committee, Stroke System of Care Task Force, and the CRAC System of Care Task Force. Dr. Sather is also the State EMS Medical Director, as well as local medical director for a number of North Dakota EMS agencies. So we're fortunate to have Dr. Sather on our team, and I'm going to turn it over to him to talk about the acute stroke process at Trinity Health in Minot.
Any page, Jana?
I sure.
All right. I want to really just talk about process and process improvement, and I'm I think a pretty cool guy, so I try to put things in simple terms, I hope. And one of the things in emergency medicine, you know, when I think about sick, hospitalized patients and EMS versus ER versus ICU and versus the floor, in emergency medicine we tend to think of, you know, things happening and changing over minutes. And in ICU, they tend to look at things more on an hour-by-hour basis, where when someone's on the floor, things, you know, and changes are looked at on a daily basis. So as we move up front on processes, we think of quick change, and what we do initially makes a big difference in some of these time-sensitive diagnoses. And so, if you flip to the first slide, one of the things we really have to think about is really what is our goal. And, when it comes to stroke, we know it's getting that treatment as soon as possible, and that makes a difference. And I've been around long enough. I remember when TPA was coming into being, and you know, 20 years ago when TPA was first coming around, and we looked at the time frames, very few people that really, you know, fit the nice mold. And I think of all the things that we put ourselves through and patients through to determine if they were a candidate. And really, we think about really what's the goal, and we look at research is pretty much showing that the earlier you give this medication, the better patients are. And in fact, it does work. And so we're very aggressive of trying to get done what needs to be done quickly. And I think if you want to do that quickly, you have to look at your whole process and eliminate upfront anyway the things that really aren't important in making that decision, and really look at the things that are important in making that decision. And I always circle back and fill in all of the blanks and the details, but you want to get that intervention done as quick as possible. If you flip to the next slide, really talks about exactly that. Eliminate or delay any steps that you don't need to do to achieve your goal. And so the things like some of the details of exam, details of history, all those things we peck away into the computer and putting in that take time, we should just eliminate those and talk about what has to be done. If I think back of some of the detailed exams and things that really had to be done, were done in the past, we'd still do those, but we don't need to do them up front in that point where minutes make a difference. So must-do steps. Let's go through those. First, you have to identify the stroke, or really just the potential of a stroke, and then initiate that person into that process. Identifying the stroke, as an ER physician, we have all of these tools to look at. I like the FAST and the FAST ED as the initial screening for a couple of reasons. One, I can remember it, and so I don't have to pull out a cheat sheet like I do to do the whole Cincinnati stroke scale. And it's quick and it's easy. And when something shows up, I can say, yeah, there's a potential this is a stroke. And so it's a one that can be done in either triage by the EMS or by myself in the hallway. And within seconds, we can help make that decision. Labs also need to be done, but unlike a few years ago, really only lab that has to be done is a blood glucose. This is quick and easy with bedside monitoring, and for ambulance patients, it's usually done prior to the patient arriving. So we don't need to repeat it if the ambulance did a blood glucose and they're telling us the blood glucose is in the normal range. And the last thing we need to do is, as far as testing, is get that CAT scan to rule out hemorrhage. What we're trying to do is rule out that this is a hemorrhagic type stroke, and that's done with a CT scan without contrast. Potential point of delay if this is not done appropriately, because there's multiple steps that has to happen. You have to get the patient to the scanner. The scan has to be done, and someone has to read that scan. And a lot of times that's a radiologist for most places. And so all of those steps need to be quick and get done. And then we have to rule out any contraindications for TPA. And then administer the TPA is the important thing. The other thing I think that is important is that we consult a cardiologist or neurologist early in the stroke to get their input. And one of the reasons I think that's important, especially in places where you don't see a lot of stroke patients, where there are a lot of TPA, some of the guidelines are changing, and they're changing very quickly. And I know my personal experience has been I've taken phone calls from outlying small hospitals where they've had a stroke which they didn't think should be TPA because of the symptoms, which I knew that, yes, we do need to give this patient TPA. So it's important to get that expert on the phone early on to help with advice, because the last thing we want to do is not give a person the proper treatment early. So if we flip to the next slide, I'm going to walk you through our process. And just like everywhere, our process is probably not perfect, and we don't do things perfectly every time, but we continually look at how everything's done on a particular patient and about how we can improve in that. And so we call a stroke alert as soon as we have an idea that a patient potentially is having a stroke, and we do this based off from either ES report or the triage process, and that hopefully can be done early. The earlier the better. In our stroke alert is a method of, it's the 911 for the hospital to get all of the help available and by to do what they need to do. And we include in that the ER physician and staff is notified. Our neurologist is notified immediately on the stroke alert. Radiology is notified, and that includes includes the CT MRI person as well as the radiologist, and pharmacy is alerted because in our facility, pharmacy mixes the TPA, so they know immediately that the pharmacist stand by, and they will look at the chart early, get the patient's weight, and are prepared to mix the drug immediately. And then it is notified, and the lab is downplayed now, as we really only need that blood glucose early on. There's two ways patients come. One is EMS. And if patients coming from EMS, we try to just process that we do with DEMI patients, and we want to bypass delay in the ER and go right to where the patient's treated. So try to go right to the CT scanner on the EMS cart because, a minute and a minute there adds up very quickly. So when a stroker is called from the field, we feel the best practice is to let the ambulance crew roll in the door, take just a 30-second pause at the door of the ER. What happens at that pause is the physician, if I'm the physician, I get a chance to quickly meet the patient and get a feel for their symptoms while they are giving the admission person, our ward clerk or nurse, the information to get them registered in the system. As we know, you've got to be in the system, in the computer system, to make things happen. And that really only takes 30 seconds. EMS almost always has a blood glucose, so we hear what that is. We ask them their last vital signs, which they almost always have a recent set for us. If the patient we feel is unstable, we might stop. Otherwise, we go right to the CAT scanner. So up to the next slide. And then similarly, we want to do the same with walk-in patients, but we don't have the benefit of having had EMS lay hands on that patient initially. So when someone walks up to the registration desk with stroke-like symptoms, we immediately place them in a bed and we'll pull some blood, get that glucose right away. That's the one blood test we need, and try and get them right down to CT scan. Sometimes that's even before an IV is necessarily established. We want to do that very quickly. And so whichever way the patient comes in, they get the CT scan early. And this process thing that has to be in place is this has to be on the top of the radiologist's read list. So in our facility, they have the possibility of flipping that to the top of the list, but they also call radiologists, and radiologist knows there's a stroke alert, so they're looking for that scan. So they look at it immediately, as would the neurologist and the ER physician. And sometimes, because our neurologist is notified immediately, if it's during the day, the neurologist usually meets the patient in the CAT scanner and will start their exam right there in CT. But once the CT is done, if it appears negative, we indicate the pharmacy to go ahead and mix. And while that's happening, the patient, we continue with the evaluation to rule out contraindications. And I always like to use a checklist because I don't want to forget something. It's important to go over a checklist. We go through the checklist, and if there are no contraindications, we will start administering the TPA. And then after that, we go on to the full evaluation, get them their EKG, get the full history, physical, and all of that. But we try to meet the goal very quickly, and then we have a feedback process, which I think is very important, that
Is it? You're finished, Arthur? Studio? Hello? Nobody else can hear anything right now? Okay.
No, I can, Gianna.
Okay, good. I was worried for a moment. I had hung up accidentally. So.
I think we lost Jeff.
Okay. I'm hoping he'll call back in here, but I think he was pretty much at the end of his presentation, so I'm sure he will join for questions. But I want to appreciate or extend thanks to all of you who joined us or participated in the webinar today. I certainly appreciate you sharing your expertise and for sharing your stories. We do have time now for questions. If you'd be able to open up for questions.
We will now begin the question and answer session. If you'd like to ask a question, please press *1. Please enter your phone or record your name clearly when prompted. Your will be used to introduce your question. To withdraw your request, press *2. One, please, while we'll wait for the first question.
And I myself have a question for Jerry. Are you still available, Jerry?
Yeah.
One of the things that Dr. mentioned we are working on here in North Dakota is a peer-to-peer survivor program where survivors can visit with each other via telephone. And especially the thought was that in those rural areas, this would be a helpful tool. Did you think it was very valuable to have a connection to your fellow peers who had also experienced a stroke with the support group there? Might not?
Yes. Do I need to say my name?
No. Nope.
Okay. I feel it's important. I would answer that.
Right. Yeah. Did it aid you in your recovery process, and you participate in that group even a year out, correct?
Okay. When we started, as soon as she started up the program, or she was having a meeting in January, I believe, was the first time we went. And prior to that, I wasn't getting around too much, but I don't remember exactly the first time, what month it was. It was, I think, in January last year, and it was good. It was good for me and my spouse. Other stroke survivors there with their spouses. I think my wife would say that if she was here, that it's for the spouses to participate. They feel for what the patient's actually feeling, and hear other people talk about problems that we may have that we're not voicing to each other.
Yeah, that's why that life changes for your loved ones as well.
Oh, definitely.
Yep.
I'm back on. I don't know where you should have gone there, but
yes, did you have anything? We figured you were pretty much at the end of your presentation.
I was in just saying that it's important to have a follow-up and process improvement.
Yes.
Like so.
Yep. All right, operator, any questions yet?
We have a question on the queue right now, and that's coming from the line of Nikki. Nikki, your line is now open.
Hi, this is Nikki Rendell. I'm the stroke coordinator in Williston. There are changes that have been made into the quintiles, into the extracting portion of things. And I asked Isla, then she had she said she would forward this on into Mindy. But I said we were going to make some changes in the, like, the patient would be transferred to other facilities and things like that, and then get that data from EMS. And states have been made in quintiles, but are we right now just waiting on putting any of that information in right now, or do we have any info for that?
So this is Mindy. Yes. So the EMS follow-up, or the EMS Special Initiatives tab, is what that data collection component of Get the Guidelines is called. And we have the opportunity as a state to make recommendations to the template that is available in quintiles now. So that's one of the items that is on the agenda for the EMS Advisory Committee, which is just newly formed on behalf of this project. In a few weeks to have that initial look at the form to make sure that the forms are those that we really want to participate in on behalf of the state. So when that has been approved by our in-state group, then we would activate and ask all of the sites to start looking to complete that form within their individual Get With the Guidelines tool. And one of the components that will track will be the pre-hospital assessment of lexical exclusion via the FAST ED tool that Dr. Sather referenced. To your question?
Yeah, and the other part is like if we transfer, if the patient is transferred from the ED to another hospital, it says please specify the hospital name. Currently, there's no hospitals listed. Are we going to be updating those? Do we need to contact Quintiles, or how do we go about that?
There actually is a way for you at your site to add hospitals to that list. And within the data entry user manual, and I can send those instructions to you if they aren't available in your menu currently.
Thank you.
There are no further questions on the queue. Again, participants, to ask a question, please press *1. You will be prompted to record your name. So wait for the next question.
Anna, well, maybe just one more comment is just that this is such a huge opportunity for us as a state to pull things together and learn from each other and topics that are one middle that maybe aren't in others, and share our strengths to continue to improve our care for stroke patients, because it's such an important thing as we.
Dr. Jim, I'm having a hard time hearing you clearly.
Can you hear better?
Yeah, that's better. Yeah.
I was maybe talking to my chin. Sorry. I just wanted to comment that this is such, while we're waiting for another question, this is such a huge opportunity through the grant to really gather all of the hospitals in North Dakota and learn from each other's strengths. And because all of us, do some things very well and maybe not other things so great, then if we pull together and learn from each other's strengths, this is an important thing for stroke survivors, as we heard, and their families. And I think our end goal is it shouldn't matter where you have your stroke, you're going to get the best care available, and I think we can really do that. We were on the way to doing that, and this is huge, this grant for us. We need everybody's involvement.
Yes, 100% with that, Dr. Sather. And we are certainly set up, I think, to really lead the nation as far as a state system of care for stroke patients, which will be to the benefit of in our state.
This time, there are no further questions in the queue. I will now hand the call back to you, speakers. You may continue.
Very much. I think that will wrap our call today with that. And I thank you for joining, and I look forward to having you on our next webinar. And we'll be reaching out to many of you to get ideas for what you'd like to see the topic for the next core webinar. So thank you, Rich, and have a good rest of your day.
That concludes today's conference. Thank you for participating. You may disconnect at this time.